Good morning, good afternoon, good evening. My name is Ali Bazarbachi. I work at the American University of Beirut in Lebanon. And today I will be talking about the frequency and impact of pre-transplant somatic co-occurring mutations on clinical outcome of AML patient receiving allogenic transplant. So this work is a study on behalf of the EBMT Acute Leukemia Working Party. So as you know, AML is a very heterogeneous hematological malignancies, including numerous genetically defined subsets. And the 2022 European Leukemia Net ELN risk classification by genetics at initial diagnosis identified multiple important somatic mutations. Most of them were classified in the adverse risk category. So this genomic classification of AML with identification of mutations in transcription factors, epigenetic modifiers, spliceosome, cohesion complex, and signaling pathways has led to a more accurate risk stratification model. However, in the context of allogenic transplant, the frequency and prognostic value of different gene-gene interaction has not been studied and actually may differ from that of patient treated with chemotherapy alone. So to address this question, we realized a retrospective registry-based multi-center analysis from the EBMT with the approval of EBMT Acute Leukemia Working Party. So we included adult patients with AML receiving a first allogenic transplant between 2014 and 2019, and for whom we have available pre-transplant genetic profile by next generation sequencing. So overall, we identified 362 allografted AML patients with available pre-transplant NGS. 85% had de novo AML, 15% secondary AML. Median patient age was 56 years. And actually, when looking to the frequency of the somatic mutation, the results were not similar, were similar but not identical to the frequency of somatic mutation in AML at diagnosis. For instance, the most frequent mutation was DNMT3A, encountered in 33% of patients, followed by FLT3, NPM1, TET2, RUNX1, BCOR, all above 20%, then NRAS, WT1, ASXL1, IDH2, STAG2, SRSF2, IDH1, TP53, KRAS, and CEBP alpha, all above 10%. So this was the frequency of these somatic mutations. So we realized a multiple correspondence analysis on 179 patients on whom we had simultaneous testing of the most frequent mutations. And we had actually two independent groups of co-occurring mutation identified. The group one was for patients with DNMT3A and or NPM1 and or FLT3 mutation, and group two was for ASXL1, SRSF2, and RUNX1 mutation. So then we looked to the effect of these mutations either alone or in combination on outcome, post-transplant outcome. We took 145 patients in CR1 with available data for these 6 mutations identified by multiple correspondence analysis. And actually, for the overall population, after a median follow-up of 2.7 years, the median PFS, the PFS at 2 years was 58%, and the overall survival at 2 years was 67%. And in univariate analysis, only NPM1 mutation positively affected overall survival. The other mutation had no effect, a single mutation. However, when we look to group mutation, the 2-year outcome were the highest for patients with NPM1, regardless of the other co-mutation, with a 2-year overall survival of 81%, followed by RUNX1 and or ASXL1 and or SRSF2 mutation with a 2-year survival of 77%. And the worst outcome was for patients with the 6 mutations unmutated with a 2-year survival of 57%. So overall, NGS at diagnosis can be extremely useful in risk stratification of AML patients undergoing allotransplant, potentially allowing adequate post-transplant pharmacological intervention. And 2 independent groups of co-occurring mutation were identified: the group 1, DNMT3A, NPM1, and FLT3, and group 2, ASXL1, SRSF2, and RUNX1. Thank you for your attention.